are live and you are good to go.
Okay, thank you. Good afternoon, everyone. I'm Dr. Holly Shaw, the chair of the NGO Committee on Mental Health. I represent the International Council of Nurses at the United Nations, and I hold several elected positions there, but this one is very close to my heart. And we're very pleased to have a wonderful program. This is our second year of dedicating a program meeting to LGBTQIA plus issues, and we have an excellent panel. I'm very grateful to Dr. FELIX TORRES, who has coordinated and will convene this event. Dr. TORRES is an officer on the executive committee and has been for several years. He holds several important, influential, and meaningful positions with the American Psychiatric Association and serves as a special consultant to them on United Nations issues, as well as his day job, which is as Director of Forensic Services for the state of Texas. I'm very pleased that he's been able to organize and coordinate this meeting, and I'd like to introduce him now to introduce our panel of speakers.
Thank you. Thank you very much, Holly, for that introduction. Good morning, afternoon, evening, wherever you might be. We're once again graced with attendees from all over the world, and hoping that more will join and will watch us later, but we have confirmed attendees from Asia, Europe, North America, and South America. The title of our program today is Converting Our Understanding Towards Inclusive Care, an LGBTQIA plus mental health program to recognize the struggles that lesbian, gay, bisexual, transgender, queer, questioning, intersex, and asexual plus individuals face throughout the world, and our need as mental health experts, providers, families, and allies to be more understanding, more inclusive, and more caring, whether in the treatment setting, but also in our day-to-day lives and interactions. I'll be the first to say that I have been fortunate in my life journey as a gay man. I may have been the subject of discrimination and ridicule, but have not experienced firsthand trauma and violence to which some of our peers have been victims. And while I prefer the term survivor rather than victim, there have been indeed those who have not survived, and to those we dedicate our program today. I was closeted for many years, growing up in a homophobic environment in Puerto Rico, and then as a young man, having moved to California and confronting the problems with acculturation as a minority within a minority within a minority, ethnically, culturally, and sexually. It wasn't until my medical school and later in residency, psychiatry residency, that I came to terms with my sexuality and accepted myself as who I am, a proud gay Puerto Rican man from the island. I am now in a 17-year relationship with my husband and just celebrated our Gemini twins' second birthday a couple of weeks ago. We have come a long way, yet not far enough. And I want to give some numbers from a 2021 Gallup poll in the US. LGBTQ youth are 120% more likely to experience homelessness than heterosexual youth. 1 in 3 transgender people said that they had to teach their doctors about being trans. 70% of LGBTQ youth said that they experienced poor mental health during the COVID-19 pandemic. 3/4 of LGBTQ youth said they have experienced discrimination because of their orientation at least once. 13% said that they have been subjected to conversion therapy. Of Black youths who identified as LGBTQ, 17% said that they had been physically threatened or harmed because of their orientation. More than half, 54% of LGBTQ Americans have hidden a personal relationship to avoid discrimination. About 15% of LGBTQ people in the US say that they have postponed medical treatment out of fear of discrimination. More than 1/4 of trans adults, 29%, live in poverty in the United States. 42% of transgender people said that they did not vote because in at least one election in the last few cycles because of fear of discrimination or ridicule. And 42% of transgender people were killed in the US in 2020, marking the most violent year on record. While non-discrimination policies, which include sexual orientation, have been implemented by 96% of Fortune 500 companies in the United States, there have been nearly 240 anti-LGBTQ bills filled within the first 3 months of 2022 in the United States, most of them targeting trans and non-binary people for discrimination, such as by criminalizing healthcare for trans youth, barring access to the use of appropriate facilities like restrooms, restricting trans students' ability to participate in school and sports, allowing religiously motivated discrimination against trans people, or making it more difficult for them to get identification documents with their name and gender. Also, so-called Don't Say Gay legislations have been enacted and continue to be proposed in the US, seeking to prohibit schools from using a curriculum or discussing topics of gender identity or sexual orientation. As we know, there's also significant disparity in how knowledge of diversity and inclusion is imparted to our medical residents, psychologists, social workers, and other health and mental health professionals, and how those competencies are evaluated and treated, how those competencies in the evaluation and treatment are assessed. If we expand that to the global arena, the issue is even more dire and is in need of considerable attention. So I certainly hope that today's program will contribute a little bit to that powerful grain of sand in that beach that I call diversity, equity, and inclusion. So to that effect, we have an excellent panel today and I will introduce.
Excuse me, Dr. Torres, can you there's a question about where on Facebook they can follow live. Is that?
I will, it's on our NGO CMH site, so look up NGO CMH.
Yeah.
Where it's at right now.
NGO CMH or Committee on Mental Health.
Yeah, and I will put it on the link as soon as I yield to Jack.
Thank you.
All right, thanks, Holly, and thank you for the question,
You.
All right, so our first panelist is Dr. Jack Drescher. Dr. Drescher is a psychiatrist and psychoanalyst in private practice in New York City. He is the clinical professor of psychiatry at Columbia University, College of Physicians and Surgeons, and a faculty member at Columbia's Division of Gender, Sexuality, and Health. He's also a senior psychoanalytic consultant at Columbia Center for Psychoanalytic Training and Research, and an adjunct professor at NYU's postdoctoral program in psychotherapy and psychoanalysis. He is a training and supervising analyst at the William Alanson White Institute, a distinguished life fellow of the American Psychiatric Association, and past president of the Group for Advancement of Psychiatry, and also a past president of the APA's New York County Psychiatric Society, the New York County District Branch. The title of his presentation today is Sexual Conversion, Reparative Therapies, and I will read you a little bit of the abstract. The presentation reviews the history of mental health attitudes toward homosexuality from the 19th century to the present. This is followed by a discussion of how sexual orientation change efforts shifted from a clinical debate to a culture war issue. The presentation goes on to discuss some of the problematic clinical and ethical issues raised by efforts to change sexual orientation, and concludes with a summary of the position statements of the professional mental health organizations regarding sexual orientation change efforts. A friend, a colleague, a mentor. I know Jack as far back as my residency days when he would teach on the module on sexuality during my residency at St. Vincent's Medical Center in New York. So my pleasure to welcome you, Jack, once again, and the floor is yours.
Thank you, Felix. Thank you, everybody, for coming. I'm going to talk on sexual conversion therapies. This talk is going to focus on conversion therapies of homosexuality. The subject of conversion therapies of gender identities is a talk of its own. So this is the table of contents. I'm going to talk about the history, some of the diagnostic history, this issue as a culture war issue, some of the clinical research issues, ethical issues, and then some of the legislative actions that have taken place. So I'm going to start with the history of mental health attitudes toward homosexuality. The term homosexual actually is invented by a Hungarian journalist in 1869, but it becomes popularized in 1886 by a psychiatrist from Germany, Richard von Krafft-Ebing, who thought of homosexuality as a mental disorder as part of a theory called degeneracy theory. Degeneracy theory was a 19th century theory, which we no longer believe in, that said that many nervous conditions were the result of degeneration of the nervous system due to a decadent lifestyle. But the 19th century is when homosexuality began to be classified as a mental disorder. Freud took issue with this theory in his 3 essays on sexuality. He called homosexuality inversion during much of his paper. He argued that homosexuality was not a degenerate condition because it appeared in primitive societies, which had never arrived at decadence. And also homosexuality was part of the culture in ancient Rome and Greece at the height of their civilizations, not just in the decadent era. So he thought of homosexuality as a developmental arrest that is not quite an illness, but not quite normal, which is to say, calling somebody childish may not be as offensive as calling them sick. But again, it was not a respectful way to think about homosexuality. And he wasn't very confident about the ability of clinicians to try and change a homosexual orientation. As he wrote in a 1920 paper, in general, to undertake to convert a fully developed homosexual into a heterosexual does not offer much more prospect of success than the reverse, except that for good practical reasons, the latter, that is the reverse, is never attempted. And Freud, who died in 1939, one of his last words on this is a letter that was found years after his death, in which presumably it's called the Letter to an American Mother because some woman in the United States wrote to him, presumably to help change her homosexual son. And Freud wrote back to her that homosexuality is assuredly no advantage, but it's nothing to be ashamed of, no vice, no degradation. It cannot be classified as an illness. We consider it to be a variation of the sexual function produced by a certain arrest of sexual development. But the psychoanalysts who came after Freud took a very different view. They disagreed with him. They redefined homosexuality as a perversion. One of the most influential psychoanalysts was Sandorado from Hungary, who came to the United States and who went on to actually to found the Columbia Psychoanalytic Center, where I recently became a member. And he didn't believe in Freud's theory of bisexuality. He didn't think that there was such a thing, and that homosexuality in adulthood represented an avoidant anxiety of the other sex. And then there was very famous psychoanalysts in the middle of the 20th century. Irving Bieber led a study with a group of psychoanalysts. They analyzed 106 homosexual men and compared those analyses to 100 heterosexual controls. They concluded, they started out with the belief that homosexuality was a disorder, and their study concluded with the idea that a pathological family constellation causes homosexuality, and they claimed a 27% cure rate for the people that they treated. A few years later, about a decade later, a psychologist, Clarence Tripp, challenged Bieber to produce one of his cured patients, and Bieber filed an ethics complaint against Dr. Tripp with the American Psychological Association, which was dismissed. And again, one of the most famous anti-gay psychoanalysts was Charles Socarides, who claimed in his 1995 book that he cured 35% of the people that he treated. But while psychoanalysts were pathologizing homosexuality in the middle of the 20th century, you have what we think of as modern sex research, which is a move toward a view of homosexuality as a normal variant of human sexuality, similar to the idea of left-handedness not necessarily being an illness, although there was a time when left-handed children were actually exposed to a kind of conversion therapy to make them right-handed. And I'll touch upon some of the most important research in this area. The important point to keep in mind about the research, psychoanalytic studies of homosexuality were based on patients who came into treatment and prison populations, whereas the modern sex research went out and did field research. They went out and they interviewed people who were not patients necessarily and tried to find out what people were doing who were not seeing psychiatrists for other reasons. So Kinsey, there's a movie about Alfred Kinsey, which I highly recommend. was very interested in the evolutionary importance of variations within species. He actually started out studying wasps. He was an insect taxonomist. And he and his group did thousands of detailed interviews about people's sexual practices who were not patients. He came up with a Kinsey scale, which I will show to you. And his study found high rates of adult homosexuality, anywhere from 10 to 37% in adult populations, which argued in favor of a normal variation. Today, we think, first of all, we know that this is a skewed sample because you had to be willing in the 1930s and 40s to answer, an interview about your sexual history. But the studies today sometimes say anywhere between 1 to 4%. They're very difficult to do because how you phrase the question will give you different answers from different people. And this is the Kinsey scale, which Kinsey 0 being exclusively heterosexuality, and Kinsey 6 is exclusive homosexuality, with 5 grades of bisexuality in between Kinsey 1 to 5. Kinsey scale has entered the popular imagination. If you do a Google search using Google Images, you'll find many people's views of who constitutes pure heterosexual. This is from Dr. Seuss's The Grinch Who Stole Christmas to Frosty the Snowman being exclusively homosexual. Another person who did a lot of work that was very influential was Evelyn Hooker, psychologist on the West Coast of the United States. She did a study comparing 30 gay men who were not patients with 30 heterosexual controls. At the time, it was believed that homosexuality was not just a sexual disorder, but a disorder of global mental functioning. And so she gave 3 projective tests to her 60 subjects. She asked the 3 leading experts of the 3 tests to judge, to review the results of the 60 subjects, but they were blind in the sense they didn't know which of the subjects were gay and which ones were not. And the blind judges could find no significant differences between the 2 groups. And the fact that there was no evidence of psychopathology in these non-patient gay men population was at odds with the prevailing dominant psychoanalytic theory of the time, which supported a normal variant point of view. But many psychiatrists and psychoanalysts did not like the Kinsey report. They attacked Kinsey because he wasn't a medical doctor, for example. And Hooker's work was published in something called the Journal of Projective Techniques, and was an illustration of how the scientific literature from one discipline does not necessarily enter into the thinking of another. So the psychoanalytic theory and the sex research theories did clash finally in what came to be the 1973 APA decision to remove homosexuality from the DSM, with gay activism as a catalyst for that change. So what happened in 1969, June is Gay Pride Month, because the Stonewall riots in June of 1969 was a case of gay people fighting back against police that raided the gay bar. This was a very powerful moment. Apparently, it set off 3 days of rioting here in New York City's Greenwich Village. It also galvanized a pre-existing gay rights movement. There'd been a gay rights movement in the United States since the 50s, but it was a very polite gay rights movement. People would get dressed up, men in suits, women in skirts and blouses, wearing very finely printed signs saying, please give us our rights. But the United States in the 1960s was being roiled by social unrest. We had an anti-war movement against the Vietnam War. We had a Black civil rights movement, which had some violent aspects. We also had a women's movement. Women were demanding their rights. And suddenly the gay rights movement turned from polite to a little bit more aggressive. So in 1970, the gay activists came to San Francisco and they disrupted, that is, they zapped the APA meeting there, took the microphone away from the doctors talking about their cures for homosexuality and said, you better start listening to us. This did give APA pause, and they actually paid attention. So in 1971, APA gave the gay activists a panel, gay men and women who are not patients, to talk about their lives, to explain to the psychiatrists why they were hurt by this diagnosis. And that led to another invitation to the following year to the APA. And the panelists thought, wouldn't it be great if we can get an openly gay psychiatrist on the panel as well? But in 1972, homosexuality was illegal in most US states. You could lose your job, nobody would send you a patient. You might not be accepted into psychoanalytic training for sure. And so they found a doctor who was willing to appear on stage if he could do so in disguise. And so this is Dr. John Fryer, which is what I say is, this is what an openly gay psychiatrist looks like in 1972. And Dr. Fryer is there with Barbara Giddings and Frank Kameny, two of the gay activists who had organized the protest against the APA. And Dr. Fryer told his fellow psychiatrists, I'm in hiding because if you knew who I really was, I would lose everything I have. I have to hide. I have to pretend to be straight like everybody else. And this really had an enormous impact on the psychiatry. This is Dr. Fryer, shortly before he passed away in 2003. While all this is going on, there's also a lot of committee work going on. There are scientific committees who are reviewing the literature, and they decided that the sex research literature was more scientific than the psychoanalytic literature. And so in 1973, APA's Board of Trustees voted to remove homosexuality from what was then the DSM-2. The psychoanalysts, however, were not happy about it. The board took place during the December meeting of the American Psychoanalytic Association. So they gathered 200 signatures to petition the Board of Trustees, to petition the membership to overturn the Board of Trustees' decision by having a referendum. This bylaw, which was meant for administrative decisions, not scientific decisions, has been changed, so they can't do that again. And APA had 20,000 members at the time. Half of the membership voted, and 58% of the members voted to support the board's decision. Now, this was a subject that entered into popular culture when the board voted to remove homosexuality. It was on the front page of the New York Times, which was not a small thing. But, you know, it's important to think about, I like to dissect what was the vote actually about, because most psychiatrists at the time were trained in an illness model. So if you had asked them in the referendum, do you think homosexuality is a mental disorder? The majority probably would have said yes. That's not what they were asked. They were asked, do you support the APA Board of Trustees scientific process in coming to the decision to remove? That is, do you trust the experts who went through a process? And that was what the membership voted to support. Now, what's interesting, when I was a resident, there was a chapter in Kaplan and Sadok, the textbook of psychiatry, where I now write the chapter on homosexuality. But in that year, the opponents of the removal would later argue that science cannot be decided by a vote, but they usually fail to mention that they were the ones who asked for the vote in the first place. But that actually begs the question of whether scientific questions can be decided by a vote. And the answer is yes, absolutely, because in 2006, the International Astronomical Union voted that Pluto is no longer a planet, because in science and medicine, objective facts are often filtered through human subjectivity to reach consensus, which is why I always tell people that DSM, and I've worked on the DSM-5 and the DSM-5 text revision, DSM-5 is not a Bible, it's a user's manual, and it changes as our conceptualizations of what constitutes a disorder changes over time. And it has changed over time, not just around homosexuality. And this is poor Pluto being shunned by the other planets. So this is just a listing of homosexuality in the DSM. It was included among sociopathic personality disturbances, sexual deviation by the DSM-2. It's worth keeping in mind that in 1973, when homosexuality was removed, it wasn't removed entirely. It was replaced by something called sexual orientation disturbance, which meant that whether you were heterosexual or homosexual and you were unhappy about your sexual orientation, you had a diagnosis and you could see a psychiatrist who could presumably charge for the meeting by using a code. Since there aren't a lot of heterosexuals seeking psychiatric treatment to change their heterosexuality, this was changed in 1980 to ego-dystonic homosexuality, which meant if you were unhappy about your homosexuality, then you had a psychiatric diagnosis. But this came under criticism because there are many things people are unhappy about in their lives. If you feel you're too short, should you have ego-dystonic height disorder? So by DSM-3 the revision in 1987, that diagnosis was removed. And mostly that diagnosis was a political compromise between the people who wanted something in and the people who wanted the diagnosis out. DSM-4 had an example of persistent and marked distress about sexual orientation as an example of how to use the wastebasket category of sexual disorder, not otherwise specified, and that was removed entirely from the DSM-5. And so there are no such diagnoses anymore in DSM. So now I'm just going to talk about sexual conversion therapies in a cultural context. So one aftermath of the APA decision was the growing cultural normalization of homosexuality. And it went something, if I would summarize it, it's a little bit like this. If homosexuality is not an illness, and if one does not literally accept biblical prohibitions against homosexuality or other religious prohibitions, and if contemporary secular democracies separate church and state, and if openly gay people are able and prepared to function as productive citizens, then what's wrong with being gay? And there are polls which consistently show that knowing someone who's gay, either a family member, a friend, a coworker, a neighbor, increases tolerance and acceptance of homosexuality. So what happens in the culture wars is you have a pro-gay political side, which tries to create the means by which more people will come out as part of its civil rights movement. But the anti-homosexual side wants to make it more difficult for gay people to come out. They wish to create obstacles to right with the hope of putting the genie back in the bottle, that if you make it difficult enough, maybe these gay people will go away. And one of the tools in this culture war is what I call the resuscitation of sexual conversion therapy. Psychoanalysts, for example, having lost the vote that I mentioned in 1974, they actually refused to accept the normal variant model of homosexuality for almost 20 years. The American Psychoanalytic Association did not reverse its policies in which they refused to treat openly gay men and women until 1991, and they only did so after threat of a lawsuit. And so these people who believed that homosexuality was an illness became increasingly marginalized in the mental health professions. In 1990, the ICD also took out homosexuality, but replaced it with something called ego-dystonic sexual orientation, which was removed in the ICD-11, which just came out in 2019. And so the conversion therapists, after the American Psychoanalytic was no longer the most comfortable home for them, they founded their own organization called NARTH, the National Association for Research and Therapy of Homosexuality. And these were people, some of them were therapists, some of them were not, who believed that homosexuality is a mental disorder and that those who so desire should receive treatment for it. And their theories were a coupling of religious, faith healing, and secular psychoanalytic theories. And they provide religious and social conservatives a dissenting, scientific sounding voice to counter the mainstream views of homosexuality. In 2014, NARTH closed shop and they renamed itself the Alliance for Therapeutic Choice and Scientific Integrity, even though they're really not very, their integrity is questioned, at least in terms of science. And so if you look at the arguments, I've tried to break it down into the two opposing views of homosexuality in the culture wars. You have a normal identity model and an illness behavior model. The normal identity model assumes that homosexuality is a normal variation of human expression. It rejects historical and cultural beliefs that view homosexuality as either an illness or immorality. That is, it rejects biblical interpretations. It also believes that to accept one's normal homosexual orientation is regarded as a distinguishing feature of a gay or lesbian identity. That is, this is a position that supports coming out. It defines those with a gay or lesbian identities as a member of a sexual minority. The popular term is born gay, keeping in mind that we don't know why anybody is heterosexual or homosexual. We don't know what causes any sexual orientations, but the more that people believe you're born gay, the more likely they support gay rights. But like members of other minorities, gay men and lesbians need discrimination protections. Again, the creation of the civil rights movement. The other side rejects the normal identity model. In some ways, it's very anti-modernism, virulently anti-scientific, when scientific findings appear to contradict biblical teachings, and it in fact resembles the politics of intelligent design, which doesn't believe in the theory of evolution. This model regards any open expressions of homosexuality as indicative of a psychiatric illness, a moral failing, or both, and so therefore it upholds traditional anti-homosexual moral values. This model doesn't believe that you can create a normal identity from illness or sin, nor can this provide a basis for defining membership in a sexual minority group. So they refuse to recognize the gay identity. Homosexuality is just defined as a behavior, not an identity. And they also will argue that a right to engage in homosexual behavior cannot be compared to the rights of racial or ethnic minorities. And so they refer to gay rights as special rights. So returning to after 1973, the illness behavior model, which gradually became marginalized from the mental health mainstream, was taken up by a social conservative political movement. And they argue that if homosexual behavior can be changed in just one person, then homosexuality cannot possibly be inborn. Of course, this is a problem because it conflates biology with immutability. There are many traits that are not changeable, that people are not born with, but that's another lecture. But they will argue, and this is because they're arguing to popular beliefs, not in science, if homosexuality is not inborn like race, then gay people cannot and should not be considered a minority entitled to legislative protections, which created something called the ex-gay movement. So this is an example of an ad that appeared in Florida in the 2000s. The Florida legislature was debating whether to pass hate crime laws that included sexual orientation. That in the United States there were laws that are additional penalties if you attack a person based on hatred of some quality of the person. So if you attack a Black person that you didn't know just because he was Black, that could be considered a hate crime in addition to being an assault crime as well. So many gay organizations have tried to include hate crime, sexual orientation in hate crime laws. This is an advertisement in the newspapers that was opposing the inclusion of sexual orientation. And it says, here are 4 ex-gays who are saying hate crime laws say we were more valuable as homosexuals than we are now as former homosexuals. So what is the message here? Well, one is homosexuality is not innate like race because we were once gay and now we are not. And therefore, and the other message is hate crime laws should be opposed, that is hate crime laws for sexual orientation, because gay rights are special rights. And that was the message. But one of the things that was occurring is that, there was a small number of ex-gays who got used over and over again. As Wayne Besson, who has written about this, he called them ex-gay for pay. There actually was a cadre of people who are professional ex-gays. So I've marked 2 people at the end of the ad, the woman on the left, the man on the right. And here they are, picketing the American Psychological Association, arguing in favor of conversion therapies. And there are many people like that. Alan Chambers is an interesting guy because he was the head of Exodus International, which was a conversion therapy movement. He closed down the organization about a decade ago, admitting that people cannot change their sexual orientation. But for years, he would appear as a representative of the reason why people should try to change. So how does this work? So the ex-gay anti-homosexual political agenda does parallel the intelligent design movement, as I said earlier. One is to present an issue to the public as if it were a debate in the mental health professions, which it's not. To finance and promote ideological experts in think tanks like NARTH or the Family Research Institute, to provide personal testimonies of ex-gays for pay, to discredit the science, motives, and methods of mainstream mental health organizations. This is going on now around trans rights as well, by the way, because this is a template for how they operate over the last few decades. To attack individuals whose work undermines their agenda, like Kinsey was accused of being a pedophile, attacks on gay professionals themselves or their straight supporters, and to try to confuse the public with pseudoscience and selective scientific citations. So the ex-gay movement fell into decline. In the 1990s, it was co-opted. It came to life on its own in California, actually, but it was co-opted in the 1990s by the religious right in the United States in an effort to stop marriage equality. And starting in 2004, as marriage equality started first in Massachusetts and then began to spread to other states, the funding of Exodus began to dry up. As I mentioned, Alan Chambers, Exodus's president, stated that conversion therapy doesn't work, and they closed the organization in 2013. I'm now just going to move to some clinical and research issues. Well, there's little research on either the benefits or harms of sexual conversion therapies. The published reports, peer-reviewed published reports, indicate the majority who try to change do not. The claims of benefits are often overstated, while the concerns raised by opponents about possible harms are dismissed. There's a use of a faith healing model as opposed to traditional medical or psychology models. There is a belief that there's no harm in trying, a belief that underlies a lack of scrutiny of these approaches. There's no selection criteria. Regardless of the probability of success, anyone who wants to try can usually find someone who will treat them. And one other issue, really important, is patient motivation rather than skill of therapists or the efficacy of the treatment is cited as a primary factor of change, which often leads to the patient blaming themselves rather than the therapist when the treatment fails. And since most of these treatment fails, a lot of people blame themselves. After the treatment fails, patients can feel worse. This is how I got interested. I used to see people in my practice in the 1990s who had been in previous therapies. These are patients who were older than I were, had tried to change. And when they couldn't change, they blamed themselves. They questioned their faith. They questioned their own motivation. Also, which could be reinforced by a therapist who defined the lack of change as resistance using psychoanalytic jargon. The failure would sometimes lead to worsening of depression, the onset of anxiety, and sometimes even feelings of suicide. But those feelings are never reported in the literature of the people who perform sexual conversion therapies. Another harm is that patients were sometimes encouraged to marry during the course of treatment into a heterosexual marriage, and they were often encouraged to do that by the therapist. And when they didn't change, some families would break apart. And some religious families that don't believe in divorce, the married couple would stay together, tragically tormented. And there's some studies that show that years of trying to change would delay the decision to come out, and the treatment creates what someone has called a spoiled gay identity, which creates problems in intimacy and sexual problems after they actually do come out. So this is the APA, part of the APA position statement on conversion therapies, which first came out in 2000. I won't read the whole thing for you, but the COP is Commission on Psychotherapy by Psychiatrists recommended that ethical practitioners refrain from attempts to change an individual's sexual orientation, keeping in mind the medical dictum to first do no harm. The American Psychological Association issued a task force report in 2009. You can Google this report online. It's downloadable for free. And it affirmed that same-sex sexual and romantic attractions, feelings, and behaviors are normal and positive variations of human sexuality, regardless of sexual orientation identity. They reaffirmed the position that homosexuality per se is not a mental disorder, and it opposed portrayals of sexual minority youths and adults as mentally ill due to their sexual orientation. They concluded there is insufficient evidence to support the use of psychological interventions to change sexual orientation. They encouraged mental health professionals to avoid misrepresenting the efficacy of sexual orientation change efforts by promoting or promising change in sexual orientation, and concluded that the benefits reported by participants in sexual orientation change efforts can be gained through approaches that do not attempt to change sexual orientation. There, from a clinical perspective, a very famous study came out in 2003 by Robert Spitzer. Dr. Spitzer was famous for chairing the committee that helped the APA decide to remove homosexuality from the DSM-II back in 1973. In the late 1990s, he became interested in the question whether some people can change their sexual orientation, and published his paper in the Archives of Sexual Behavior. It's important to keep in mind that this was not a publishable paper. He tried to publish it in the Journal of the American Psychiatric Association. And as he said, he got more feedback about what was problematic about the study than any paper he had ever submitted. So what the Archives of Sexual Behavior did is they published the study, but they also published about 20 peer reviews, most of which were critical. Had they actually done an actual peer review, it would never have been published. But they published it, became an enormous story around the world. There were 200 subjects, 143 men and 57 women, who had a 45-minute structured telephone interview. The majority reported that there was some change from a predominantly or exclusively homosexual orientation to a predominantly or exclusively heterosexual orientation. So there were many methodological criticisms, such as no follow-up or face-to-face interviews, that the study used retrospective accounts and did not use any physiological measures of homosexuality. They had a difficult time recruiting 200 subjects. The subjects were actually recruited through NARTH members and their patients. And there was a subject recruitment sample bias as well. 20% were professional ex-gays, as I mentioned. Of the treatment that led to change, only 47%, less than half, saw an actual mental health professional. Another 34% joined an ex-gay religious support group, and another 19% claimed, among their other claims, is they met a heterosexual role model, reading the Bible, bibliotherapy, or changing their relationship to God. But Dr. Spitzer repudiated his own study in the archives. He wrote a letter, and he said there was no way to judge the credibility of subject reports of change in sexual orientation. I offered several unconvincing reasons why it was reasonable to assume that the subject's reports of change were credible and not self-deception or outright lying, but the simple fact is there was no way to determine if the subject's accounts of change were valid. I believe I owe the gay community an apology for my study, making unproven claims of efficacy of reparative therapy. And I also apologize to any gay person who wasted time and energy undergoing some form of reparative therapy because they believed I had proven that reparative therapy works with some highly motivated individuals. I'm going to conclude by talking about some ethical issues. So Paul Applebaum is a past president of the American Psychiatric Association, was on a panel about conversion therapies. This is an unpublished paper. And he said, he has also chaired the ethics committee of the American Psychiatric Association, and actually just recently led the DSM-5 text revision process. So Dr. Applebaum said that in order for a treatment to be considered ethical, there should be a reasonable basis to believe it's effective. There should be appropriate disclosure of relevant information to the prospective patient, which is called informed consent. There should be an absence of illegitimate pressure on the patient. The patient should be able to make a competent decision, and there should be a fiduciary devotion by the therapist to the patient's best interest. I'm going to discuss all of these just briefly. Is there a reasonable basis to believe treatment may be effective? Well, the literature in this area does not cite any, you can't find the words efficacy, effectiveness, or treatment in a search. There's no scientifically accepted body of research data to support the position that these treatments are effective. As I mentioned earlier, that one of the early studies in 1962 claimed a 27% cure rate, but when challenged just to provide one sample of a cure, the lead author of the study filed an ethics complaint rather than provide data. And I guess the question is, it all depends on what your definition of reasonable is. How about informed consent? Well, informed consent done by conversion therapists is highly subjective. Often it involves disparaging APA, both APAs in the mental health mainstream, saying that homosexuality really is a disorder and that APA has been taken over by gay activists. There's an overemphasis on unproven causative factors such as parents and dismissing of biological studies. There's a lot of stereotyping of homosexual lifestyle, that is, all gays lead unhappy lives, gays cannot form relationships, gay men die young from AIDS, etc. And they really rarely discuss any possible harm of treatment. What about coercion? Well, many therapists in this field have a conflict of interest. They act as agents of conservative social institutions rather than agents of the patients. So for example, students in religious universities are required to undergo sexual conversion treatments or face expulsion. Therapists in those situations will actually break confidentiality to inform or threaten to inform parents, church, or university officials if the patient does not cooperate with the treatment. And these are communities where if they were to do so, the patient would be expelled from their community. Clinicians will refuse to accept the patient's decision to terminate, and they continue to call patients long after termination to encourage them to return to therapy. And the therapists threaten dependent patients with termination if they quote unquote act out. And then there's the fiduciary devotion by the therapist to the patient's best interests. So Applebaum said the therapist must be willing to tolerate any outcome of treatment, whether it results in a full or partial change in orientation or in the affirmation of the patient's same-sex orientation. This is not a position endorsed by therapy literature. And a lack of referrals to therapists who could help a patient develop a gay identity after the patient decides their conversion treatment has failed. The patients are usually abandoned once they give up trying to change, unless they are willing to accept celibacy as an option. So to summarize some of the issues in sexual conversion therapies, the illness behavior model idealizes heterosexuality and denigrates homosexuality. There's poor selection criteria. Changes infrequent may cause harm. Ethical violations may include subjective informed consent, breaches of confidentiality, improper pressure placed on patients, and a relinquishment of the fiduciary responsibility to patients who eventually come out as gay. Then there's the final ethical question. This is something that has come up actually this week. I got a call that the Greek parliament has passed a law banning conversion therapy for minors, but they did not want to pass a law banning it for adults. So I was asked by my colleagues in Greece if I would have anything to say about that, because the argument is that adults should have the right to choose treatment. So this was the patient's right to choose was first came up in a Wall Street Journal editorial by the late Charles Socrates and other North officials saying, don't forsake homosexuals who want to help. And conservatives have argued adults should have the right to choose conversion therapies. Well, the issue of it is an ethical principle that people should have competent adult individuals should have the right to choose, but the principle of patient autonomy is sometimes in conflict with the ethical principle of first do no harm. And should a person be allowed to choose treatments that might be harmful to them? Well, one historical example is a drug, Laetrile. Laetrile was a drug that was marketed in the 1970s as a cure for cancer. It was actually studied and found to be not able to help, and it was even harmful. The Food and Drug Administration here in the United States banned Laetrile, but there was a Laetrile movement, people who wanted it, even though you couldn't get it in the United States, they would go to Mexico to get it. And people were harmed because they did not get treatment for their cancers that might have helped them. They delayed treatment, and some people might have died. So it is possible for medical authorities and government authorities to say, if something is harmful to the people, then it shouldn't be allowed to be done. And then there's the Vioxx was another example of a medication that was put on the market. It was approved for the public, but the testing process that brings it to market has a limited number of patients. When it went on the market, there were many more people who tried Vioxx than had been tried it in clinical trials, and they found that it had cardiac side effects. And so the drug was withdrawn from the market as more information was gathered. And finally, there are people can get cosmetic plastic surgery that they might not need. People are destroying healthy tissues to get the nose they want, the breast that they want. But the standards of care, the kind of work plastic surgeons done is a level of peer review and research that doesn't exist in the conversion therapy movement. So the final question is, why don't patients who feel they've been harmed by conversion therapy file ethics complaints? What they say is they always blame themselves because they asked for it. The patient saw the therapist as concerned, although perhaps misguided. He only tried to help. And then many patients feel shame that they actually voluntarily submitted to this, and they wouldn't want anyone else, like a licensing board or an ethics committee, to know about it. Legislative efforts. I'm sorry, I thought I was done, but just to talk briefly, there are sexual orientation change efforts, gender identity conversion efforts. The first ban in the United States was in California in 2012. It was challenged in the courts, and that law was modeled by other states. There are now over 20 states and the District of Columbia of the United States that ban conversion therapy for minors. No one is banning it for adults, basically on the consent issue. These are countries that ban conversion therapies. As I pointed out, Greece just recently banned it, New Zealand, etc. And around the world, many states, cities, and provinces have introduced legislation to ban both kinds of conversion efforts. And in 2020, there was a report from the United Nations Independent Expert on Protection Against Violence and Discrimination based on Sexual Orientation and Gender Identity that called for a global ban on practices of conversion therapy, a process that must include defining the practices, ensuring public funds are not used to support them, banning advertisements. I was contacted by Facebook once to help them go through their advertisements to say, well, which of these ads are conversion therapy advertisements? Some of them are well hidden. Establishing punishments for non-compliance and investigating respective claims, and creating mechanisms to provide access to all forms of reparation to victims, including the right to rehabilitation. They recommend that states take urgent measures to protect children and young people from practices of conversion therapy, carry out campaigns to raise awareness among parents, families, and communities about the invalidity and ineffectiveness of and the damage caused by conversion therapy, adopt and facilitate healthcare and other services related to the exploration, pre-development and/or affirmation of sexual orientation and/or gender identity, and to foster dialogue with key stakeholders. And that's it. I have an LGBT mental health listserv, which I'm the only one who posts. My email address is jackdreschermd@gmail.com. If you'd like me to add you to the listserv, just tell me who you are and why you want to join. And that's it. Thank you for your patience.
Thank you very much, Dr. Drescher, for your presentation. I think we will hold questions until the end. I will then now introduce our second speaker for today. All right, our second speaker is Dr. Elahe Ashtari. Ella, as she joined McGovern Medical School in 2016 as an assistant professor in the Department of Psychiatry and Behavioral Sciences. She's a licensed clinical and forensic psychologist and received appointment as Director of Psychology Services at the UT Health Harris County Psychiatric Center, where she oversees the operations of the Inpatient Psychology Consult Service. Additionally, in 2020, she became the inaugural Vice Chair for Diversity and Inclusion in the department, and she chairs the Psychiatry Inclusion Council. A recent colleague here in Texas after my move, we have been collaborating on several aspects, and I am pleased to have her join us today. The title of her talk is LGBTQ plus health disparities and best practices. And just a brief mention of our abstract. LGBTQ plus individuals experience a range of discrimination and stigma, which contribute to health disparities as well as mental health and substance use disorders. Many well-intended people are often unsure how to communicate with and about this minority group in compassionate and affirming ways. In this presentation, relevant and new terminology related to gender identity, gender expression, sexual identity, and sexual orientation will be provided. Additionally, LGBTQ plus health disparities will be identified, and inclusive communication strategies related to the LGBTQ plus community will be highlighted. Thank you again, Dr. Ashtari, and the floor is yours.
Thank you, Dr. Torres and the NGO Committee for Mental Health for this invitation. I am really pleased to be here. Also, thank you to Dr. Drescher. I think I said your name correctly. Feel free to correct me if I didn't, for that excellent history related to this topic. I went through and kind of made some minor revisions to my slides so that I didn't become a redundant speaker on the history. So that's great. Thank you. So let's go ahead and get into it. So as just mentioned, the learning objectives today will be related to terminology, health disparities, and then the things that we can do to be more inclusive and affirming with those we know or maybe don't know, identify with the LGBTQ plus community. As you probably already know, LGBTQ plus stands for lesbian, gay, bisexual, transgender, and other gender identity, basically identities or sexual orientations. So queer or questioning kind of is, well, the word queer was basically previously a slur that was used against the LGBTQ community. But more recently, the community has basically reclaimed this term and is interested in, in using it to identify themselves. Of note, though, there's also some folks who don't want to be called queer, so only call people queer who identify that way. But it is another umbrella term for LGBTQ+. So DSM or SGM are also umbrella terms that you might see in the empirical literature, or you might hear people refer to this community this way. DSM refers to diverse sexualities and genders. SGM refers to sexual and gender minorities. You may also hear SOGI, which is sexual orientation and gender identity. So these acronyms, you may see them, they're kind of interchangeable to some degree. There's not one correct umbrella term. It is more of a preference, so it's good to be familiar with all of them. And so I want you to know, as we talk about terminology, these are all subject to change. There's not a, forever term, I think. Even homosexuality is a term that is oftentimes sneered upon nowadays. Like, some people don't want to be called homosexual. Some people do not identify as homosexual, and we'll talk more about that. But if someone identifies that way, that's how you should identify them as well. Research has really tried to understand the common characteristics for each orientation and identity. Research with this population is very difficult. It can, a lot of people can be very reluctant to disclose their identity and orientation for fear of discrimination, stigma, fear of being outed in some way. So, and there are obviously cultures and government systems across the globe that continue to persecute gender and sexual minorities. I may not be representing, every single culture group here as we discussed today, but I want to make sure that we're also going to be thoughtful about individual differences, and every person is different, and we don't stereotype or make assumptions based on the terminology that I'm going to offer today, because not everyone who identifies, for example, as gay is just like every other gay person. So I want to continue to be mindful of assumptions and stereotyping, because labels oftentimes can contribute to that inadvertently. And related to labels, remember, people identify for themselves how they identify, whether that's sexual orientation, identity. Others should never distinguish that for an individual, regardless of their gender expression, or if they tell you they're in a same-sex relationship, that doesn't automatically mean that they are gay or lesbian. So keep that in mind as well. So let's talk a little bit about what identity, expression, and orientation are. Sex obviously refers to someone's sex assigned at birth. So whether they're male, female, or intersex, they may be assigned that by a doctor, typically based on their anatomy at birth. And that's all sex really identifies, is their anatomy. On the other hand, gender is defined socioculturally. So what we know is that, for example, in the Western culture, have you ever thought about who decided that pink means girl and blue means boy? It was just socially constructed. There's really no real reason for that. We decided long ago as a culture that these colors or attire would be associated with a particular gender, but they don't really signify anything but color. Gender identity, right, is a person's sense of being masculine, feminine, androgynous, or another gender. Gender expression refers to how someone presents physically on the outside. It's mostly what you see. And that's really mostly what you're seeing is their expression. It's often represented through attire, mannerisms, demeanor, etc. Again, culture and society often determine what constitutes as feminine or masculine, or somewhere in between, like androgynous. And then sexual identity is the label that people adopt to represent the other, to others, who they are as a sexual being, and how they, and that sometimes relates to their sexual orientation. It's not 100% that it will, as sexual orientation is the desire. So it's more of an internal desire. The orientation is the desire for intimate, emotional, intersexual relationships with people of maybe the same gender, sex, another gender or sex, or multiple genders and sexes. So an example is someone could identify as heterosexual, be involved in a same-sex relationship, but they do not identify with being gay, lesbian, or queer. This level of individualized identity can also impact research. It can also impact, for example, if I was researching sexual orientation in Indonesia, I should not simply ask if they identify as lesbian, gay, or bisexual. I should ask if someone has had or is involved in a same-sex intimate relationship. This would likely produce different results than if I just simply asked what label they would select. Importantly, related to sex, remember, genitals do not define someone's gender. All right, so a little bit more about gender identity. While we think we know how someone identifies their gender based on their expression, we're oftentimes in those circumstances making an assumption. We have to be thoughtful to avoid making those errors and consider that there's more to a person than what we can see. These are a few gender identities. There are 30 or more gender identities out there. Obviously, we don't have enough time for me to cover every single possible term, but we can't really discuss gender identity without also understanding pronouns, especially in the English language. Not every language includes pronouns. Like I was born in Iran, I speak Farsi, and in Farsi, we don't have gendered pronouns, interestingly. But in English, we do, and we use them pretty often. So in the English language, most common pronouns are she, her, he, him, they, them. Some of the less common pronouns here are ze, here. There's others, and you will use whatever people tell you to use for them. We're going to discuss how to use pronouns and how to kind of share our pronouns with others in a moment too. So in terms of gender identities that are common, like I said, I just have some of the common ones here. Is cisgender woman, cisgender man, cisgender non-binary. Cisgender woman, cisgender man. And then here we have basically I'm a cisgender woman. I was born a female and I identify as a woman. So I'm considered a cisgender woman. So cisgender in and of itself is not a gender identity, but cisgender woman or cisgender man is. Non-binary, genderqueer, or NB stands for a gender identity that falls outside of that binary male-female category. And so these are just newer terms. So if you've never heard of, for example, NB or genderqueer, they're newer terms. And so, like I said, none of this is going to, last forever. Things will change. Some of this is fluid, and we have to remain educated. Similarly with transgender, transgender non-binary, transgender woman, transgender man, that's the full gender identity. I have motion censored lights, excuse me. Transgender on its own is not a gender identity, and transgendered is inappropriate kind of use of that term. So a little bit about gender identity there. Now let's get into some sexual orientation terms. And again, these are the most common, but that doesn't mean this is an exhaustive list. It is not. And so when we refer to orientation, we're characterizing attraction to others romantically, erotically, or emotionally. So lesbian refers to a female identified or non-binary person attracted romantically, erotically, or emotionally to other women or non-binary people. Gay, well, this is often about male identified people being attracted to other male identified people. This orientation can also represent any sort of same-sex attraction. So some lesbians will just also identify as I'm gay. A term about homosexuality, because homosexuality was relevant to a disorder for so long. More senior individuals that identify as lesbian or gay may be okay with the term homosexual, and like I said, they may identify themselves that way. That's fine if they do, but we should not be identifying people with that term unless they do, because it can have some negative connotation for some of the LGBTQ community. And then we have bisexual or fluid. This refers to a person who's sexually attracted to more than one gender. Usually there's a preference for one gender, and attraction is not typically split 50-50. It's not like a bisexual individual is going to date a man and then date a woman and then date a man and then date a woman. There's some preference, but that they are very attracted to both or more than one. Queer refers to that general term of non-heterosexual status broadly, okay? And then, as we all know, heterosexual straight refers to being attracted to a gender that's different from our own. Pansexual, when one is attracted to all genders and they're not really concerned with their gender when they're considering attraction. So that's different than, say, being bisexual. And then questioning are individuals who are currently in that place of contemplation. And this is something we're going to talk a little bit more about too when we talk about coming out. But questioning is oftentimes a very typical part of coming out with self and then coming out with others. Asexual has often been misunderstood as an aversion to sex, but it's not. It's lacking attraction. It doesn't have to include an aversion to sex. And then demisexual is an orientation that's somewhere on that asexual spectrum. Again, there's not enough time to include the asexual spectrum here, but asexuality includes demisexuality, which is sexual attraction to people that occurs only after one has formed a really strong emotional and intimate bond with them, regardless of their gender. Given that, I want to say really directly that normal is a myth. Okay, it is a statistic. It's not a human characteristic. So conceptually, notions of normal fuel discrimination and stigma for LGBTQ+ people. And so notions of what constitute normal obviously vary across cultures, ethnicities, societies. And just because the majority of people are straight and cisgender, that does not mean that those who are not straight and cisgender are abnormal or sick in some way. So you may recognize some of these terms, but basically the phobias that we probably know really well have evolved into isms. So I'm going to go through those a little bit. Heteronormativity, you may know, is a general assumption within institutions, cultures, again, governments, that everyone should be heterosexual and that heterosexuality is superior to other sexualities. Obviously, this leads to invisibility, discrimination, stigma. Heteronormative cultures and systems also contribute to people keeping who they are private, feeling oppressed, stigmatized, and this oftentimes will result in, people kind of having mental health issues. A person's gender expression, again, is not related to gender identity or sexual orientation, even though heteronormativity likes to say that that's what it should mean. An example of heteronormativity, right, is when you learn a colleague who is a man is expecting a baby and you excitedly ask him when his wife is due. This conversation piece is certainly well-intended, but not inclusive. And you made the assumption that he's married to a woman. You assume that the woman that he is married to is pregnant. And how did you arrive at those conclusions, right? Where did that come from? Those are your assumptions about what it means to be a man expecting a baby. But your colleague could have been married to a man who, and they could be gay or they could not be, but married to a man. It's possible that they had a surrogate carrying their baby. It could be that they were planning on adopting. You could keep in mind also that heterosexual couples could be utilizing a surrogate as well. So again, don't make assumptions. And I think that's within that heteronormative mindset that if a man tells you they're expecting a baby, that obviously they're married to a woman and that woman's pregnant, but that's not fair. Cis-sexism was formerly known as transphobia. And so that's the bias or prejudice that favors cisgender people, suggesting that cisgender is superior to other genders. An example is that you meet a new client whose documented sex is male in the chart, documented name is Jordan. They report they identify as a transgender woman and present with feminine gender expression. You never ask their pronouns, so you continue to use he, him pronouns and use the prefix Mr. with your client. That's an act of cis-sexism. And then monosexism is formerly known as biphobia. This incorporates a range of negative attitudes and assumptions that one may have about bisexual people. You know, oftentimes there's even within the LGBTQ community, bisexual people are often discriminated against. But there's a misconception that being bi means you're promiscuous, or that you're going through a phase, or having an identity confusion, or are greedy and want your cake and eat it too. An act of monosexism is when we tell our bisexual colleague that they should just pick a side already, because they're never going to be happy if they don't. Heterosexism, formerly known as homophobia, is a term for negative attitudes that one may have towards LGBTQ people. It suggests that being straight is superior to being a sexual minority, often denotes fear or disgust or discrimination towards sexual minority people. You know, an example of this is when your colleague who is a man comes out to you as gay, and your response is, "No, I bet you just haven't met the right girl yet." Certainly you had good intentions, but you insulted your colleague and engaged in discrimination. So we want to be mindful of the things that we're so used to thinking, and kind of challenge our biases a bit. I really like this image here of the sexual trichotomy, because I think it really helps us understand that human beings are just not black and white and simple. You know, how we identify with ourselves, who we're attracted to, and the sexual behaviors in which we engage could potentially be different. And the factors may be related to one another, but not necessarily. So for example, a woman could identify as heterosexual, feel attraction to both men and women, but only engage in sexual behavior with women. So most individuals self-identify their sexual orientation, but obviously there are others who do not prefer labels at all. Some people like labels because it helps them better understand who they are and share with others who they are. Some people do not like labels at all because they feel like it's merely a way of having others make sense of them. So both are fine, and we can respect others' individuality, but it's important to be aware of that. All right, we already kind of discussed Kinsey, but it's I have to share this in order for us to talk about you know, sexual orientation. It's really helpful to understand human sexuality on a continuum, and as Dr. Drescher said, you know, Dr. Kinsey in the 40s conceived this skill from interviewing thousands of people, even though his research was a focus of controversy and he was criticized for like statistical methodology. His work has been profound in understanding sexuality. And instead of assigning people to hetero, same-sex, and bisexual categories, the continuum can help us understand where people fall kind of on a spectrum. This idea that even if you can acknowledge the sex appeal of another of the same sex, that maybe you're not quite at that 6 or 0, right? You're not that polarized, and maybe you fall somewhere on this spectrum. So I think it's a helpful way of understanding individuality of sexual orientation. All right, coming out. So oftentimes people understand coming out as when we share with others our sexual orientation or gender identity, but coming out is the process by which an individual comes to terms with their own identity and orientation, as well as coming to terms with telling others. It can be very challenging for people from different cultures and faiths, and those whose family and, like I said, religious backgrounds suggest that they're not going to be accepted for who they are. Coming out is, again, defined by internal and external sharing. It's a personal decision that's based on safety, comfort, and readiness. And we all know that we should never tell someone they should hurry up and come out, because it is based on that safety. And a lot of people may not be safe coming out to certain people in their social circles. So we want to be mindful of that. You know, most people that identify as LGBTQ are out in many contexts, but there might still be some settings or contexts where they're not comfortable coming out. You know, keep in mind too, coming out is not oftentimes this grand announcement. It can merely be mentioning that you have a wife, or that you have if you're, for example, me, if I had a wife, then that would be, you know, me sharing with you who I am. You don't have to then, you know, ask, so are you a lesbian? It's not necessary to do that. As an ally or colleague, everything you say is an indication of whether you are or are not a safe person to whom to come out. Keep in mind too, that even if you know your colleague is heterosexual, you don't know if their child might identify as LGBTQ, or you don't know if they had, lesbian or gay parents. So be mindful of the ways in which we can be inadvertently insensitive, because that's going to make you a less safe person to be around. One last thing I want to make sure everyone understands is that coming out is a lifelong vulnerable process. Once you come out, you have to come out in a lot of different contexts. You're going to get to meet a lot of different people in your life, and you're going to consistently be coming out. So it doesn't stop after the first time, and it is a very vulnerable experience for many people. So when they do come out, what can we do? Someone comes out to you. Do know that obviously they trust you, and remember intersectionality too, is that being queer is just one aspect of someone's identity. There's obviously other identifiers like race, ethnicity, nationality, disability, spirituality, etc., which all of these will affect their experience as well. So obviously we know that there are cultures with strict adherence to gender roles and stereotypes. And be mindful that if someone comes out to you, they really trust you. Check in on confidentiality. Maybe say, is this something that you are open about, or should I keep that confidential between us? Or keep in mind too that intersectionality, that's not all they are. Show curiosity and interest in what they share. Ask them even how you may be able to support them if that's relevant. But don't say things like, oh yeah, I knew that, or I always knew that. Don't go telling everyone about your new trans friend. Oh yeah, did you know I have this new trans friend? Don't ask probing questions or cross boundaries that you wouldn't cross with anybody else in your life who may not be a sexual or gender minority. Don't assume either that you know why they came out to you, and ask that, don't also go and ask them like, if they provide you with their partner's pronouns in some conversational tone, don't then ask, are you gay? Those are ways that we can really kind of shut people down or turn people off. So you all may be very familiar with the minority stress model, but this model indicates that because of sociocultural structures and systems that are in play in our environment, minorities, when compared to majority groups, experience a disproportionate level of prejudice and discrimination over the long term. And because of that, minority individuals have to develop adaptations beyond that of their non-minority counterparts. Therefore, based on this model, minority groups are more likely to develop a host of health risk behaviors and possible conditions. Let's take a close look, though, at some of those health issues that are relevant to LGBTQ individuals. So, greater than 50% of LGBT people endure discrimination, slurs, microaggression, sexual harassment, and violence. 20 to 40% experience healthcare discrimination because providers aren't adequately educated. I've created some curriculum here at the school where I'm faculty, but there's a huge move to go ahead and improve and augment the education related to LGBTQ healthcare. Consistent with that minority stress model, internalized stress leads to mental illness. It's not being LGBTQ that results in mental illness. It's that being LGBTQ makes you vulnerable to so many experiences that can contribute to mental health symptoms, right? Lack of social programs. There's also a lack of social programs, right, targeted for this group, especially youth and elders. There's a shortage of healthcare providers that are knowledgeable. Violence victimization affects LGBTQ people, especially gay men and transgender women of color. Many LGBTQ people live in poverty, especially those that identify as transgender. Some employers will discriminate against LGBTQ individuals and may not offer partner benefits. We all know that simply having an anti-discrimination statement is not sufficient for the culture of an institution to actually be accepting and inclusive. Access to healthcare is limited. Social and faith-based discrimination exists. Many schools don't offer supportive services for LGBTQ youth. There's a presumption of paternity that basically indicates that, for example, even though in 2015 in the US, gay marriage was legalized, having a child within a same-sex partnership, even if you're married, if there's a parent that gave birth, they're the automatic custodial parent, but the other parent is not considered a custodial parent unless they go through the second parent adoption. So that's obviously a lengthy and costly process. Due to time, I'm not going to cover that in depth, but I'm going to keep moving here. Sexual minority women, when compared to sexual majority women, are at an increased risk for substance use, suicidal ideation and attempts, having a mental illness, especially major depression, generalized anxiety. They're more likely to experience obesity, poor physical health, and report asthma. And they're at equal or greater risk for intimate partner violence. LGBTQ plus individuals are 3 times more likely to experience a mental illness. They're, due to the violence, risk, discrimination, stigma, and fears related to and the aftermath of coming out. This can result in depression, anxiety, PTSD, suicidality, substance use. LGBTQ individuals are at an, like I said, they're also at an increased risk of suicidality. Those ages 10 to 24, suicide is the leading cause of death for those LGBTQ individuals between the ages of 10 to 24. Sorry, I didn't say that right. Substance use is significantly more common among this population. 20 to 30% of LGBTQ people abuse illicit substances compared to 9% of the general population. 25% of LGBTQ people abuse alcohol compared to 10% of the general population. And keep in mind, these numbers are likely either decreased or exacerbated in cultures and countries where being LGBTQ plus is punishable by death, dismemberment, or being disowned by family, for example. I have this here, but because of time, we're going to keep moving. But I do want everyone to think about how you demonstrate to your LGBTQ plus peers, clients, colleagues, that you are inclusive, sensitive, and safe. I say demonstrate here because we all have really good intentions and we all strive to do our best in our interactions with others, but it's important to reflect on our intentionality and how our intentions are reflected through our actions. Intentions are not often visible, so our actions are. And so we really want to be mindful of how am I demonstrating that I am safe, inclusive, and sensitive, right? What can I do regularly to create a culture where LGBTQ plus people feel safe and included? And again, these could be our consumers of where we work or where we kind of engage daily or regularly, but this could also be our colleagues, our friends, our family members even. So keep that in mind as well. All right, so some things that we can do to demonstrate that we are inclusive, right? We can avoid using words like sir, miss, or mister, okay? We can try not to ever refer to someone as an it or he, she. It has actually happened at the hospital where I work, and that has really been really bad. No, you don't ever want to do that, obviously. Avoid using words like wife or husband. These are all gendered terms, right? Avoid using gendered terms like boyfriend, girlfriend. Do this with all people, regardless of whether or not you know their gender or sexual orientation. Do not ask a person what their, quote, real name is. Don't use a person's, quote, dead name. Dead names are the names that people who identify as transgender, that was maybe the name that they were given at birth, but they no longer identify with that name and they have their chosen name. Don't ask them about that dead name, and don't use it if you don't need to. Refrain from asking about people's preferred pronouns. Try using the term personal pronouns. This was a newer issue that came out in the LGBTQ community where after Pence and Kamala Harris had a debate, preferred and preference kept coming up relevant to this community. And so, people don't like it. Don't use preferred anymore. Don't make any assumptions, okay? That's kind of the biggest takeaway, obviously. It's important. Here's some things you can do instead, though, okay? Here's some tools. State your name and pronouns. Hi, I'm Dr. Ashtari. My pronouns are she, her. How would you like me to refer to you? Less common pronouns, they, them, theirs, ze, here, hers. You may use MX, pronounced mix. If you're not sure how to refer to someone and you feel like you need a prefix there, you can use that, mix Smith. You make an honest mistake, apologize quickly, but don't make it awkward. Don't apologize profusely. Be familiar with the various terms related to LGBTQ people and consistently educate yourself and update yourself. These are fluid and they're changing. And I think it's important that we stay informed. Use partner, spouse, or significant other. Even if you identify as a heterosexual cisgender individual, referring to your partner or your spouse or your significant other takes nothing away from you, but it demonstrates that you are an inclusive individual and safe. You may also, instead of saying like what's your real name, you can say what is the name on your identification, or could the file be under a different name. Include your pronouns in your signature line. You may notice here on Zoom, I also have my pronouns next to my name. You can change that in Zoom when you log in. If you have if you work in a clinic or something like that, or work for an institution that has forms, you may consider modifying your forms to be more gender neutral and allow for individuality in that way. What's getting in the way of us being inclusive? I think oftentimes it's our implicit or maybe even explicit biases. Maybe all of your friends and family members are too similar to you. Saying things like, I have gay friends or I love gay people is not really the right way to demonstrate inclusivity. Or saying things like, I don't care about who you sleep with, or I don't even see that you're Black. Those things lead to invisibility and are extremely hurtful and are considered microaggressions. So while you have good intentions, we are not demonstrating that by saying those things. Other things that get in the way are really poor boundaries. You may be drinking and say something inappropriate because we have diminished inhibition. You may not have the effective communication skills you need to have. Those are areas for growth, and continuously learning and educating ourselves is really important. Overcoming implicit bias, educate yourself, engage with others that are different from you. Check yourself, check your biases. We all have them. It's not about not having them. It's about knowing our biases and then checking them and reforming them based on new information, and then making amends and apologizing when we mess up and get it wrong. I wanted to include some things here that you can do either at your organizations or companies that you're at, clinics maybe. We talked a lot about how to be inclusive within relationships or smaller groups, but as an organization, there are also things we can do. We can include chosen name on like employee badges, signage, payroll, things like that. We can provide gender pronouns integrated into our HR software. We may even consider having gender neutral or unisex restrooms available. Regularly offering employee education on LGBTQ inclusivity. We need to have a good accountability pipeline and system in place for reporting discrimination and aggressions like that. If you don't already have one, maybe consider having an affinity group for LGBTQ+ colleagues and inviting all to that group or event. One of the hardest things I find is that we have all these affinity groups, but only those that identify with that affinity group are showing up, when really we need everybody to show up for these things, right? We need to have an inclusivity kind of mindset. And then lastly, I have here, if you have a local pride parade or festival, try to attend that and engage with this community a little bit more. They'd love to have you, we'd love to have you, and we would love to be able to kind of, know that you are a safe person. I also wear these pins at work. I have my pronoun pins here. I have a trans flag pin and a rainbow flag here. I identify with the community, but I also think it's really helpful for me to have these pins because I work in a hospital and I don't always know who I'm about to meet, but I've had people that identify as LGBTQ be really excited by seeing that signage on my person. So those are some ways that you could be more inclusive. And then I have here a few resources that the Safe Zone Project has some really great up-to-date terminology and knowledge base there that you can browse. It's free. The American Psychological Association offers publications that are available. PFLAG's a great support system for parents and families of LGBTQ people. If you have any questions, I'm also open to taking your emails, calls, anything you need, let me know. I think that's the end of my presentation, Dr. Torres. I think there's questions available at the end, is my understanding.
All right, well, yes. Thank you very much, Dr. Ashtari, for your presentation. Words matter, and they can hurt, but they can also affirm and aid someone in the process. So thank you for that. And now I'd like to turn it over to Dr. Shaw, who's going to introduce our third panelist for today.
Thank you. And thank you for those wonderful presentations. Following up on what we can do is avail ourselves of the wealth of information that's available. And that's really one of the purposes of our program meetings, are to provide information for our members who are advocates from their various organizations. And I would encourage everyone who does represent their own NGO or non-governmental organization to review their policies, review their procedures, their HR, and be able to use this information to include it. In terms of the UN, it's striking to me how many of the 17 SDGs are really applicable when we talk about these issues in terms of the statistics that Dr. Torres and you recently presented in terms of poverty, impediments to education, sustainable inclusive societies and cities. I mean, almost, I'm struggling a little bit with oceans and forests, but otherwise, every one of the SDGs is really applicable in this arena. Now, one of the purposes of civil society at the UN, and not only Congo, which is the Conference of NGOs in Consultative Relationship with the UN, but also the Department of Global Communications. These are ways that your NGOs can officially affiliate with the UN. At a conference sponsored by then the Department of Public Information in 2016, I had the delight and pleasure of meeting women from another NGO called Mama Dragons. And when we talk about multiple minorities, these women, as you'll find out, are mothers of LGBTQI adult and child offspring. So they're marginalized in many ways and facing challenges and adversities. And I was so taken with this organization. They did a presentation in 2017 for us around their suicide prevention program. And I'm very pleased that we have today Celeste Caroline, who is the executive director of Mama Dragons. And I think we have enough time for her to describe a little bit about the organization as well as their new program, which is very exciting and very much applicable for all of us to be able to use as clinicians, as faculty, in any way that we can, but also to introduce it to our organizations and again, provide Mama Dragons with more opportunities to present. So it gives me great pleasure to introduce, should I say Mix? That was kind of new to me. So Mix Celeste Carolina, Executive Director of Mama Dragons.
Perfect.
Okay, great.
Thank you. I've added some closed captioning on the bottom for those that would be helpful. I speak quickly.
Excellent, thank you.
I wanted to quickly just introduce myself and a little bit about my background and how I'm engaged with this organization. So first off, I use she, her pronouns. I'm a cisgender woman, and I've been working with Mama Dragons for about 5 years. And I come from kind of a unique background. So back in 2004, I fell out of the closet when I was outed at BYU. BYU is a Mormon university, or LDS. My very first girlfriend and I were sent to the dean of students for being gay, and I knew that I would be put on academic suspension and not be allowed to graduate until I repented. The process of being outed created great loss. I ended up being asked not to come home by my family. My good friends shunned me, and in the end, I lost my entire Mormon community. Unfortunately, that situation is still not uncommon today. Even though the world around us seems like it's been changing, more and more kids are coming out than ever, but parent rejection is still at a third of, at least in the US, that a third of our LGBT youth are still experiencing parent rejection when they're coming out. Mama Dragons is kind of unique because we really focus on accepting parents. That we have found that by having affirming parents, that children and youth are 3 times less likely to think about suicide. They have higher self-esteem and they have lower depression rates. When I came out of the closet, I couldn't keep watching others continue to suffer. And I really wanted to change things for queer people. And so I started doing research because I wanted to get involved. And I think the unexpected thing that I found is the most significant way to help LGBTQ people was for me to jump in and help parent acceptance. This is kind of where my I story changes into a we story, because I knew I wanted to make a difference, and I soon ran into this organization called Mama Dragons. And this organization was a little different than other parent groups, which often gather those who are already allies. The focus of Mama Dragons is working with moms new to the journey of supporting their LGBTQ children, and often come from non-affirming cultures and non-affirming religious roots. So by focusing on this unique demographic, we started really impacting real change at the core of the problem. Mama Dragons provides 3 critical programs. Our first is our Facebook support groups. So we have 1 main support group, 5 affinity support groups, 20 regional support groups, and also a Spanish-speaking group. We also provide, as you heard, QPR suicide prevention. We have 16 QPR certified trainers, and we do weekly trainings for our mothers. One thing that you'll notice in this training too, that I won't use the word woman or women. Our parents come to us and self-identify as mothers, and we don't have gender requirements of our group. The other programs we offer are support programs. Often when our mothers get involved with our organization, they get really excited and they want some way to give back to each other and to each other's children. And so we've created 2 other programs called Wrapped in Hugs and Paper Hugs, where moms can reach out when the kids are struggling, that there can be a lift from the community. The last program is our new program called Parachute. And Parachute is a proprietary e-learning curriculum. Mama Dragons has grown really fast. Currently, we are in every state in the US and in 12 other countries. Right now, we are about 8,500 members, and we'll be close to 10,000 members by the end of the summer. And our growth really speaks to the great need from mothers to have a support system. Right now, 30% of our members report that they're identified as LDS or Mormon. 20% report that they're Christian, and 10% of our members identify as not being religious. We have found that kind of that intersectionality of parenting, that when someone is identified or connected to a conservative community, that the change of parenting of LGBTQ child generally creates some type of faith change. So through the process of working with parents and surveying mothers about their parenting journey, we found a really interesting gap between when their kids came out to them and when parents found support. And this gap often resulted in misinformation. So in response to this need and a lack of other resources available, Mama Dragons created Parachute. We raised over $100,000 and built an academic research-based curriculum to build affirming parenting. Currently, we have 4 courses available, and they are the LGBT community, the coming out experience, understanding LGBTQ labels, and then how to show affirmation with action. Right now, 90% of respondents have indicated this course has improved their understanding of providing affirming parenting to LGBTQ children. We were also recently able to translate these first courses into Spanish. We added closed captioning to all videos, and we also added audio to make them more accessible. The other really unique thing to these parachute courses is through understanding how parents really make the change of affirming their children. It is generally not through statistics or books or all those traditional ways that we learn. It's often hearing their story in somebody else's story. And so this curriculum isn't a traditional college course. It's more of a storytelling course full of videos, animations, and hearing other mothers' stories of their process with their child. Today, over 60% of moms joining Mama Dragons have kids under the transgender umbrella. These kids are being attacked by anti-trans legislation and laws throughout our country, which increase their already high rates of suicide. Research shows that an alarming 42% of LGBTQ youth seriously considered attempting suicide in the past year. That number includes more than half of transgender and non-binary youth. Today, Mama Dragons is working to build additional resources for parents with transgender youth. These include gender identity expression courses, parent support and advocacy, social transition pronouns and names, and how to access things like medical care and mental health care, which seems to be a fairly large blocker for our parents. So this kind of quickly summarizes Mama Dragons and what we do for the community. And I just want to extend just the gratitude I have for programs like this that increase awareness and education around the LGBTQ community, and any support that any of your programs or connections can offer us. All we want to do is expand that mission of making our world safe for our LGBTQ children. So thank you.
Thank you very much, Ms. Caroline. Are there any questions? I don't see any in the chat.
I think one of the things that we could do as a committee is provide a structure and a space for within the UN civil society sector to be able to take some of these courses and have Mama Dragons really help model some of this for our community, which is very diverse, global, and certainly will benefit from all of this. And I'd like to encourage those of you who aren't members of the committee to please go to the website and join as members, and also to consider, if this is an interest that really speaks to your heart, that you join the working group on LGBTQI plus matters. And we're hoping that in the fall, when we maybe we'll meet again in person at the UN, but certainly also continue a hybrid, that will have very active working groups and be able to do things like sponsor courses, also write some position and policy papers on behalf of our constituents, and be able to really be part of not only allyship, but advocacy and activism to make real changes in our own civil society community, our larger communities, and of course the global community. So there's lots of opportunity for those of you who want to become involved. And when I met Mama Dragons, it was a small group. I'm just blown away at the magnitude and enormity of your contribution in what seems like just a few years. It's really just wonderful and so inspiring when we hear these bleak statistics and wonder about the sources of cruelty in the world. The idea that change can really happen with individuals and small groups is very inspiring.
I would like to open it now to any questions from our audience. And I think Dr. Astari was trying to connect with Mama Dragons, Ms. Caroline, on how to get some of those resources to parents and patients that you serve.
Sounds like maybe the website's the best way then, Celeste. Okay.
Yes, and we also offer Parachute for free for therapy groups that support LGBTQ youth. So if there's therapy groups or organizations that fit within that, I mean, our goal is really just to extend our reach of how do we really help parents help our youth.
Wonderful, thank you.
And Dr. Drush added the Family Acceptance Project as a resource in the San Francisco area. Yeah, Dr. Congress?
Yeah, hi. Yeah, I'm sorry I had a conflicting meeting, so I came late, but I really enjoyed, hearing you, Dr. Estari, and also, hearing about Mama Dragons too. It's so inspiring. I mean, you really raised my consciousness, and I tried. I'm a social worker and also a psychologist, so I try to be very conscious of, of being using appropriate language. But it really made me re-examine the ways that I've been doing it. So I guess my question is, where can we, and it's changing a little bit over time, because I know some of the things that I started out with are really taboo now. So what is the best guide for the most current, respectful way to talk, to address,
That's a great question. Yeah, and I'll be honest, I mess up. Like, I'm not perfect. Nobody is. The point is to be, aware, I think, right? And so when we mess up, we have to apologize. I think that's the appropriate thing to do because we didn't intend to mess up. I will say that I think the Safe Zone Project is probably one of the best free resources available on the web. I'll go ahead and put that website in the chat here in a second.
Oh, great.
But I strongly recommend them. They have a great resource guide. They have a whole curriculum, all free. It's run by volunteers, but it's really good and it's very up to date. So I would definitely recommend that to kind of maintain or augment your continuing education for sure. Thank you for asking that.
And I guess, thanks. And also I had a question for, and I'm sorry to catch your name, the person who spoke about Mama Dragons. That was very interesting. And I think I had heard about the organization, but I'm sure it's particularly challenging now. I mean, I found in talking to, like some parents who I've met, I mean, it's not as much of an issue for their teenagers to come out and say something like, I think I'm gay or I'm a lesbian, but they're really floored by a child who they've always regarded as a girl or a boy suddenly comes out in terms of transgender. And I just wonder, these are particularly challenging. And I'm sure that this is something that Mama Dragons should really try to work on and with parents.
Yeah, I think that you're right. Like, I think that people can wrap their head around sexuality a little more than gender identity, and that our parents need more resources when it comes to having a transgender child and understanding what terms like non-binary means and how to support them through the process. Because often we see our kids too coming out not just once, but multiple times as they explore their gender identity and sexual orientation. And that's also the parents get the one thing and they're like, wait, you were pan and now you're something else. And how do I adapt to that? And I guess the hard part is parents need a safe place to kind of ask those tough questions and make those mistakes, and that they're not using their kids as the resource, that they can check in with their children and be like, hey, I learned this thing. Does that apply to you? But they're really finding their resources outside of their children.
And also, this is something that they can't, or they they can't talk to their relatives about it. They can't talk to their friends about it. So I mean, this is a great resource to find people who would be supportive and also educative about ways to to work with your child when he speaks about there I go again. When your child speaks about thinking that they're transgender.
Right. And some parents go through a grieving process when their kids comes out with varying gender. And again, that's not appropriate to process with your child, but a group of other parents who have gone through that before is a really helpful place to be like, here's some helpful tips of how to process some of that, or some things of what I did to make sure I got my kids' pronouns correctly, because I knew I was hurting them every time I got it wrong.
You know, I think also one of the things that struck me when I first met with our colleagues in Mama Dragons was the tremendous sense of loss of the faith-based community, because most tragedies that we go through when we're in a crisis and need support, many turn to the faith-based community for additional support. But here was a situation where they were not only deprived of that, but shunned and rejected. And I wonder if also within the UN system and civil society sector, we have several committees that are around religious tolerance. And again, if they could be resources, both in terms of support and information, but also policy, and being able to, some of our key leaders in civil society are representatives of some of the major religious denominations. And so working together, SDG 17 partnerships, in terms of policy and recommendations and interacting with the faith-based community might be helpful, and another area in which to make change.
Absolutely. You're completely right on that too, that when parents are starting to learn and advocate for their child, if they come from a conservative environment, they start questioning their beliefs, questioning their own, like, where did I learn this? Is this right? And in that, they lose their faith community. And in areas like Utah, 25% of our members are in Utah. They lose not just their faith community, but they lose their family. And so it's a very isolating experience that these parents go through, and their children.
Is that getting any better, Celeste? Or is that, as other social movements seem to be moving in some directions, is that an area that's shifting at all, or not?
Forgive me for interrupting. Somebody has had her hand up for a long time. And maybe before we run out of time, maybe we could hear from her.
Thank you.
Katie.
I was about to recognize her.
Oh yeah, no worries at all. I had a question, and it was being answered throughout, so I really appreciate all of those follow-up questions. I was just wondering how to approach your community practice with LGBTQ youth when the family or the community itself is really conservative or not supportive of their child's gender identity. So how do you support them, like, as a professional, while acknowledging their gender identity and affirming that, but then also not disrespecting their parents or creating some sort of divide within their household?
Good question.
So I could speak from, I'm also an MFT intern, kind of strange. One other adaptation into that. I think one thing that I've seen therapists that work with our parents do and professionals is to identify the aspects of the religious culture that support their children. Like love is a pretty common system to use. And like, how would this look to love your child? How would this look if we were using a Christian denomination of, like, what would Christ do for your child? Something like that, right? Like, so using kind of the construct of their system, the religious system, but also giving some psychoeducation on some of the data that you heard today, that we know that conversion therapy is not this thing, and that we know that it is so common that it's not abnormal, that it's not a choice. I think a lot of folks that come into Mama Dragons from a conservative religion still believe it's a choice.
I put in the chat a document by the Religion Committee and the LGBT Committee of the Group for Advancement of Psychiatry, which is worked out together with a group in San Francisco called the Family Acceptance Project. And a lot of that has to do with their work with the Mormon Church. They've actually been trying to work with the Mormon Church. It's called Faith Communities and the Well-Being of LGBT Youth. So you can, I put the link, you can download the PDF. It offers some ways of talking to parents, or helping parents. The Dutch model for children who have gender dysphoria or gender incongruence is really one about working with the families and the social structure to try and, and help them understand what their gender atypical child may be going through. And so it really requires, I think I do a lot of family counseling. I see a lot of parents whose child has come out to them, and I say, it's not good that your 15-year-old knows more about this than you do. So the issue is really, what do the parents think? Not treating them as bad people because they don't think the right things, quote unquote, the right things. To try and get a sense, as in any family case, what is everybody's position on the particular subject under discussion? Try and empathize with their position, and if you can empathize with everybody in the family, maybe you can move some people to to consider the possibility of rethinking their positions.
Thank you. We're coming to an end. I want to be mindful of everyone's time. I'm pretty sure we can continue the conversation, and we shall continue the conversation within our own groups and within our own networks, because it's really important. I want to thank Dr. Drescher, Dr. Akhtari, and Ms. Carolyn for your comprehensive presentations, which are really a reminder that we need to do more to support research addressing the mental health of individuals throughout the gender continuum, including the persistently marginalized and victimized transgender population. Support research also on intersectionality, as our struggles as LGBTQIA plus individuals are compounded by between our orientation and gender, but also our other social identities. Strongly advocate against laws and policies that give carte blanche to discriminatory practices, support our children and youth, and be mindful of the language that we use. Words matter, have meaning, as I was saying, they hurt, but also affirm and support. I would like to thank you all for attending and participating in our second annual NGO Committee on Mental Health Program, fully dedicated to LGBTQIA plus mental health during World Pride Month. I welcome you to join our NGO Committee on Mental Health. I just dropped that link again, and really express your interest to join any of our working groups, including the working group on LGBTQIA mental health. You'll see the link there. And once again, thank you all for your attendance today, and I look forward to working with you in the future and seeing you elsewhere.
And thanks for putting together such an excellent and helpful program, Dr. Torres. We really appreciate it.
Thank you. All right, take care, everyone.
Bye.
Evening, morning. Bye-bye.